Hello everybody, I am Prem Ranjan and I am an audiologist by qualification. I work for the product management for EAS at Medal Headquarters Innsbruck. I would like to welcome you all on our topic on electroacoustic stimulation systems, and I would like to give you a presentation on that. I hope you benefit with that and we can have some questions later. So in the range of the hearing implants, what we have, it ranges from cochlear implant, which will help when somebody has any hearing loss in the cochlea. We have the electroacoustic systems, which would be useful when we want to stimulate the ear acoustically in the lower frequency and electrically in the higher frequencies. We have the vibrant sound bridge for different types of indication for conductive, mixed and sensory neural when there is a pathology which is in the middle ear. We have the bone bridge, which is also indicated in cases where we have some middle ear pathology. And we have the auditory brainstem implant, which would be useful when there's some retrocochlear lesions. Recently, we also have a new device, which is Adhere, which is helpful in conductive hearing losses. That's a hearing aid, and that could be utilized as a precursor to implanting solution of the bone bridge. So a little bit of a history, because we have a long history of electroacoustic implants, and I would like to briefly let you know that we have a long history into this system. The first patient was implanted in the year 1999 in Frankfurt by Professor von Ilberg. And then in 2004, we introduced the Flex24, and the first child with the EAS was implanted. We have the first generation of the EAS audio processor, which was the Duet system, which was introduced in the year 2005. We got the TÜV approval for the EAS indication in 2007. And in 2009, we introduced the second generation of the EAS audio processor, which was the Duet 2. Very importantly and very interesting that we received the Duet 2 approval for children in the year 2011. So there was no more age restriction anymore for all the age group for EAS indication. And in the year 2014, we entered into the third generation of the audio processor with the introduction of the Synchrony EAS system and the Sonnet EAS audio processor. In 2016, we achieved a very important landmark when the EAS system was FDA approved by the US clinical governing body. So we learned that we have a long history of almost 18 years, and we would be soon celebrating our 2 decades of the electroacoustic systems. And that is why I'm quite confident in saying that we have a very good history, we have very good experience with these devices, and we know exactly what we can do, how we can help the proper indication to such patients. Let's have a look a little bit at the indication audiogram. As you can see on the screen, you see that the left thresholds, the low frequency thresholds, what you see in the audiogram is quite good. It is in the mild range. And then the hearing loss is progressing on to become profound in the mid to high frequency. So you see typically this is a sloping hearing loss. And what is important to note here is that typically these patients can hear some sounds which are centered in the low frequencies, but what they miss out are the sounds which are in the higher frequencies. What this also implies is that we understand that in the speech spectrum, the vowels mainly have low frequency energy concentration, and the consonants have high frequency energy concentration. And typically these users can hear the vowels in the speech, but they miss out on the consonants. So what this means, what this implies is that these users or these potential patients can hear something, but their speech intelligibility is very poor. So what we can do in these cases, as you can see, we can stimulate the low frequencies acoustically with the hearing aid unit on the Sonnet EAS processor, and the higher frequencies, the mid to high frequency, could be stimulated electrically through the cochlear implant electrode. This is the indication audiogram which came up in the hearing group consensus meeting, and they are trying to widen the indication criteria so that we can have little more number of more clinical population which we can bring in who can benefit from the EAS systems. It is important to note that in all these indications, we have to collectively see that how much of the area could be stimulated acoustically and what part could be stimulated acoustically. Also, we see that in the recent trend of different groups doing their own research, what you see on the screen is the indication audiogram which comes from the group of Skorzinski from Poland. And you see that they have defined a lot of indication audiogram for partial deafness treatment, where they are trying to achieve electric stimulation only, electric acoustic stimulation, and also that you can do electric stimulation only to a certain point and natural acoustic stimulation. So with the indication audiogram, what you are seeing right now, it is very important when you look at the below the indication audiograms, you see that they are also trying to define the length of the electrode which should be used in these particular cases, because it would be important about till what degree of insertion that you want to do electric stimulation, and from what degree of insertion do you want to do natural acoustic stimulation or acoustic stimulation through hearing aid. Not only that the audiogram is important in these conditions, we have to make sure that there are other additional indication criteria which should also be met, and they are the monosyllable scores. They should be less than or equal to 60% at 60 dB SPL or in the best aided condition. No history of any rapid progressive sensory neural hearing loss, because we want the low frequency hearing loss to be stable, because we are going to utilize that post-operative, and that is why we do not want any history of any progression of the hearing loss. We also want to rule out any conductive component, and that is why we would want the earbone gap to be less than 15 dB. That is very important. We do not want any malformations or obstructions of the cochlea which might inhibit a smooth insertion of the electrode array. And of course, there should not be any external ear contraindications which might inhibit the use of amplification device in the ear canal, because eventually we are going to use the acoustic unit through the ear mold, and that is why we want the patients to be tolerant to wearing the ear mold in the ear canal. We have to understand a bit when we are talking to these patients, when we are counseling them, we have to understand that these patients typically they are not deaf. They only consider themselves hard of hearing because they can hear something. They come to the clinic only because they are desperate. That is because they can hear something, but their speech intelligibility is not so good, and that is why they are struggling sometimes in social situations. And for them, an operation is serious and it is seen as a big risk. So in the event that they understand that they can hear something, when we talk to them about getting an implantable hearing solution, it is a big question to them that why do they have to undergo a surgical treatment when they can still hear. The success of our procedure will depend quite a lot on a few other aspects as well, which includes rehabilitation. So we have to make sure that these patients are motivated and access to a rehabilitation center for them is good, so that they can follow up with the rehabilitation. We have to make them understand, and we have to inform them that the outcomes may take almost 6 months. So they may take as much as 6 months to adjust to both the acoustic and electric stimulus simultaneously, and they can perform well. This is in speech only condition, in quiet, but studies also show that the speech understanding in complex listening environment may take as much as 2 years as well, when the patients can start performing well. It would also be very important, last but not the least, it would be very important to follow the fitting guidelines what the company suggests, because cochlear implant, the electroacoustic implantation is also a cochlear implant in the end, but how it differs from a cochlear implant procedure is basically about the fitting, and that is why fitting is a very, very integral part of this whole procedure, and so we must follow the fitting guidelines what the company suggests. Going in line with the topic, it is very important to understand that a very important consideration here is going to be hearing preservation after the speech, because we are going to implant these patients who have quite good residual hearing in the low frequencies, and we want the hearing to not deteriorate a lot post-surgery. That is why hearing preservation becomes very important. And there is an independent group of professionals worldwide, and they have this group called the Hearing Group. They have devised certain classification to classify the amount of hearing preserved, what they compare between the pre-operative condition and post-op condition. This is very nice system of classification because a lot of independent group of professionals have come together, and this is a worldwide, this is an international network where people have come together, and they found that a lot of individual groups were doing their own research and they had their own data, but there was no way to combine all that data to have research or studies with big number of patients, and that is why this group came into existence, and they are devising this classification system which takes into account the user's initial hearing. It is appropriate for all cochlear implant users who have some amount of measurable pre-operative residual hearing. It covers a whole range of pure tone average from 0 to 120 dB across all the frequency range, and it is very easy to understand, use it and imply it in the normal clinical practice. This is the paper where they are talking about this hearing preservation classification system. You may want to go through that. This is a very nice and interesting paper to read through. It gives a lot of insight about why they wanted to form this group, and also that a main objective in forming this group was to easily compare the results of previous studies and meta-analyze their data. So now what is happening is that the different groups, they are having their own patients, but they all are collecting their data in a very consistent format, and that enables the group from various countries in the world to combine their data and come up with single studies with large number of subjects. So what you see now on the screen is the website from Hearing. This is called hearing.com, and what you see on the top right and also in the bottom is the download. When you click on the download, you can download this hearing preservation calculation Excel file, what you see on the screen. It is very easy to fill in. It is quite self-explanatory. Very interestingly, you would find here that in this classification system, you have to just fill in the pre-operative audiometric thresholds and the post-operative audiometric thresholds, and it takes care also of the highest limit what you can achieve in that particular audiometer, and that is how they are trying to come up with a percentage. So the pre-operative audiometric thresholds compared to the post-op audiometric thresholds, and the Excel file already gives you the amount of the percent of hearing preservation what was achieved during the surgery. In this slide you can see the same Excel file which has been filled, and you can see that the dashed lines are the pre-op audiogram, and the solid curve is the post-operative audiogram. And what you see here where the mouse is pointing now, so S, which is the percentage of hearing preservation, was 86%. So all you have to do is you have to just go on filling the Excel file, and the Excel file is doing all the calculations in the background. So what you get in the end is directly the percent of residual hearing preservation what was achieved after the surgery. So how do you interpret that information? It is very simple, as you see on this screen now. So when the percentage of residual hearing was more than 75%, it is classified as complete hearing preservation. When it is between 25 to 75%, it is classified as partial hearing preservation. When it is between 0 and 25%, it is classified as minimal hearing preservation. And when there was no measurable hearing post-op, this is certainly loss of hearing or no hearing. So it is very easy to use, very easy to classify, and in the routine clinical practice, we all can use it. It is very nice and important to also know about the electroacoustic evoked potential tool, which is a very important and very nice tool which could be used intraoperative to monitor any additional hearing loss, if there is any additional hearing loss which is being introduced during the cochlear implant procedure. So what we see here is that we can record electrical and acoustically evoked intracochlear potentials now through the cochlear implant electrode itself, and we have the Maestro software which is helpful in getting all this information. We can also achieve near to real-time intraoperative tool, which would help to monitor the hearing status intra-op. And very nice, it can also use external acoustic stimulus. So we can use external acoustic stimuli. We can synchronize that with our recording system, and we can have a very synchronous recording of these intracochlear potentials. So in this screenshot, what you see is the setup, what we can find in the clinical software. There are various parameters which we can set. So what you see right now, where the mouse points, so the amplitude when this is 0 current unit. So what is being done right now is that there is 0 amount of electrical stimulation happening, and so it is indicating that the stimulation is being given through a EP tool acoustically. So we use basically insert receiver phones, and we can stimulate acoustically intra-op. And if we want to stimulate electrically, then we can increase the amplitude here. So this will increase the electrical stimulation, and we can do the recordings. There are some other parameters as well, but for the sake of simplicity in the routine clinical practice, all the parameters have been optimized so that the clinician does not have to change a lot of parameters in the software. So all you have to do is change the stimulus amplitude, and we can start the recordings. So this is some recording which was done by Professor Gunesh Rajan from Australia. What you see on the left is the audiogram, the pre-op audiogram, which is in the color black. And the blue and red, what you see are the curves which were obtained post-op at different intervals. And then on the right side, what you see in the top is the potentials what were recorded when the electrode was first inserted 4 millimeter into the cochlea. And then the surgeon stopped and these recordings were done. Then the electrode was advanced 4 millimeters further, so at 8 millimeters, and some more recordings were done. And similarly at 12 mm, 16, 18 and 22 millimeters of insertion depth. What is important to appreciate here is the waveform what we see. So what we want to see here is basically the amplitude of this waveform and also the latency of these waveforms. So if the amplitude is going down, that might be indicative of some intracochlear trauma which is happening, and that is why we are unable to record any intracochlear potential. And also the latency would be important. We want the amplitude and the latencies both to be around at the similar times to ensure that there is no hearing being damaged during the cochlear implant surgery. In the curves, which is in the bottom right now, what we see are 3 recordings. So first one is intraoperative, the second one is 3 months post-op, and the third one is 6 months post-operative. And what we see that basically the amplitudes here, what you see at 4 milliseconds, they are more or less constant. So this is indicative of the fact that the residual hearing is still preserved at least at 6 months post-op till what time it was measured. So a few applications where we can apply the EAEP tool is, it is place-dependent recordings of the compound action potentials, the cochlear microphonics and the summating potentials in subjects with at least some degree of hearing. We need some degree of hearing if we want to record these potentials. The navigation tool during the electrode insertion for intention of preservation of hearing. This is an excellent tool which will help educate or help train to achieve higher degree of hearing preservation in these patients. It could also be used as diagnostics for patients who are implanted with a cochlear implant. So typically patients who have partial deafness, who have some amount of residual hearing which could be measured. And for some research purposes, we can also use this tool to identify the properties of the auditory nerve and also to investigate the interactions between electric and acoustic signals inside the cochlea. Let's have a look now at the Synchrony EAS system. So basically we are talking about the Flex 24 electrodes, which are 24 millimeters in length. And if you look at the screen here, the tip of this electrode has a diameter of 0.3 millimeters. And the diameter at the end is 0.8 millimeters and the entire length is 24 millimeters. The other component is the Sonnet EAS audio processor along with the fine tuner, and we need to use the programming software which will help program these systems. Little bit more about the cochlear implant, what we are going to use. So this is the Synchrony cochlear implant, which is the smallest titanium implant. It has proven stability and reliability. It has MRI approval at 3 Tesla even without the need of magnet removal. So what is the specialty with this implant is that it has got pin design. It could be immobilized with tight subperiosteal pocket. So a very small incision and a tight subperiosteal pocket will help immobilize this implant with the help of the pin. And this will help really in the small growing skull, particularly in children, to achieve stability against any translational and rotational motions with the growing skull. This also helps the surgeon to have fast and reliable fixation method during the surgery. Very nice unparalleled MRI safety, because now we know that everybody of us in our lifetime now we are going to have at least one MRI for some or the other reason, not really because of the cochlear implant itself. And that is why this implant is now available and it is approved for 3 Tesla MRI without the need of magnet removal. This is possible because of the self-aligning magnet. So the polarity of the magnet is not axial, it's now diametric, and that enables this magnet to self-align, to rotate and self-align itself to the magnetic field in the MRI scanner. And this helps that there is no requirement of any head bandage when the patient has to undergo a 3 Tesla MRI. On the side of the audio processor, we have the Sonnet EAS audio processor. So what we have to do is we have to put the EAS ear hook. We have to make a custom-made ear mold which is suitable and which fits very nice to the patient, and we have to do the EAS fitting. Little bit more about the Sonnet EAS audio processor. So you can see all the technical specifications on the left side on the slide. What is important here to know that Sonnet is capable of giving quite high gains of 48 dB, and we can also stimulate in the acoustic range of 80 to 2 kilohertz. And very nice, what we can also achieve now is simultaneous programming of the electric and acoustic units both at the same time through the same software. So as you see here that we have different lengths of electrode to suit different lengths of the cochlear duct length. And the Flex 24 is approved for EAS indication, and this is what we would recommend to use in EAS patients. So what we are trying to achieve is that now we want to go deeper, we want to go further than 360 degrees of angular insertion inside the cochlea, and that could be achieved very nicely with the 20 to 24 millimeters of electrode insertion inside the cochlea. There is growing evidence now in the literature that they are no longer talking about the absolute length of the electrode in itself. So now we are talking more and more is about the angular insertion depth of the cochlea. And that is why it is very important to go more than 360 degrees inside the cochlea when we are doing the EAS procedure. And the physical properties of the electrode helps achieve low insertion force and low volume, which are very key and important factors for hearing preservation in these patients. Let's now look at the fitting, how we are going to do. So it is very easy to do with the new software, with the new clinical software. First of all, we need to put the air conduction thresholds, because this is the threshold which the software will use to calculate the gains for the low frequency for the patient, and also this will help the software determine the crossover frequency beyond which it will do the electrical stimulation via the cochlear implant electrode. So as you see, the crossover frequency would be put where the hearing loss crosses the 65 dB HL line. So this is done in the background and the clinician doesn't have to do anything. Step 2 is doing the cochlear implant fitting just the usual way the audiologist would do. So first you have to do the IFT, which is the impedance and field telemetry. So we check for the impedance of the electrodes inside the cochlea. Then we select the fine structure 4 strategy. We do the fitting, so we check the MCLs, we check the other parameters, we activate the device, and we check whether this map is comfortable to the patient. And that is where we stop for the moment for the cochlear implant fitting. Then in the step 3, we now move to the acoustic fitting side. And it is important here what you see on the screen that we have to put the default volume to 100%. And what you see on the screen right now is that the software has automatically calculated the gain which is required for the typical audiogram which was fed to the software. So the software has done everything. If we want to make any further changes here, so you can do that from the overall gain section tab on the right here, or the software also gives you the flexibility to drag these knots so you can increase or decrease the gains as desired by the patient. So once we have done the 3 steps, now we can activate both the units simultaneously. Just for you also to know that when we were doing the cochlear implant fitting, you could have only activated the electric side, or when we were doing the acoustic fitting, we could have only activated the acoustic side. But in the end, when we want to activate the device altogether and we want to test the performance of the patient, then we want to go live EAS so that both the acoustic and electric units are on. And now we can test the patient. How does he perform? How does he like the sound? Is it comfortable? And all that. Of course, we have to bear in mind the linguistic ability of the patient before we start testing. So we have to use age appropriate and linguistic appropriate tests for the patient for that given moment. So after talking about all these things, what is really important now towards the end is the clinical outcome. So whatever we are doing with our patients, how much are they benefiting with this? And that is why let's have a look at some of the studies and what they say. So first of all, it is very important to consider that we have to achieve both structure and hearing preservation with our EAS patients. So let's have a look at this study by O'Connell. It was published in 2016, where he talks about the consonant, nucleus consonant, the CNC score increased 0.6% with every 10 degrees increase in angular insertion depth beyond the group minimum of 208 degrees. And this is a very important indicator that we want to achieve higher depth in terms of angular insertion inside the cochlea. Another important parameter here is which electrode to choose, which will help achieve hearing and structure preservation, and also which surgical approach helps in achieving this. So as a continuation to the same study, what we see here now on the screen, on the left side, what you see are the lateral wall electrodes. The middle one is the perimodular electrode, and the last one is mid-scala electrode. The graph in black is the scala tympani insertion, and the graph in gray is scala vestibuli insertion. So we have to understand that we want to achieve only scala tympani insertion in our patients with cochlear implantation, because that is the place where we want to put the electrode, because that gives best outcomes. So what we find here in this study is that with the lateral wall electrodes, which basically means the straight free-fitting electrodes, so with the lateral wall electrodes, they were able to achieve very high degree of scala tympani insertion, as you see here. So there was only a very small number of patients who had, for some reason, the electrode which migrated into the scala vestibuli. For the perimodular electrode, we see that almost 50% only stayed in scala tympani, the remaining 50% deviated in the scala vestibuli. And also for the mid-scala electrode, it is also similar, that half of the electrodes still stayed in the scala tympani and the other half migrated into scala vestibuli. So important take-home message here is that with the lateral free-fitting straight electrodes, we can achieve higher degree of confirmed insertion of the electrode array in the scala tympani. Now let's look at which surgical approach is better to achieve scala tympani insertion. So the first graph on the right is now for round window insertion, the middle graph is for the extended round window insertion, and the graph on the right is for the insertion which were done through cochleostomy. Again, black remains for scala tympani insertion and gray is for scala vestibuli insertion. So what we find is that with the round window insertion, there was high number of cases, almost 80%, where the electrode remained in the scala tympani and only small percentage of the electrode migrated into the scala vestibuli. With the extended round window approach, we see that still the vast majority of the electrodes were still in the scala tympani and a small number of electrodes still deviated into the scala vestibuli. However, with the cochleostomy approach, what we see is that almost half of the electrodes are lying in scala tympani, but the other half of the electrodes in these patients migrated into the scala vestibuli. So again, an important take-home message here is that round window insertion is the way forward, and more surgeons around the world, they are preferring round window insertions when they want to do structure preservation and hearing preservation in their patients. Another study which talks about the predictive factors for short and long-term hearing preservation in cochlear implants with conventional length electrodes. So what they find out is that they did the audiogram after the surgery, so the first available audiogram after implantation, and then the other tests were done at 2 and 3 weeks post-operative. And what we see is that the long-term data reveals better hearing preservation for lateral wall electrodes. So this is another study by the same group, by O'Connell again. This was done in the year 2017, and here again they go on to prove that lateral wall electrodes are better when we want to achieve hearing and structure preservation. This study is to show the outcomes with the EAS system. So what you see here is that this is a multicentric study done in 5 clinics across Europe. What you see in the y-axis is the percent correct score in monosyllables in quiet. So you see 2 groups here. So one group on the left with the 5 graphs. So these are the percent improvement pre-operative in the hearing aid only condition. And on the right side, the 5 graphs you see are the percent correct scores with EAS device. And what we see on an average is that there is 50% improvement when these patients were intervened and they were given an EAS system, and their performance improved as compared to their hearing aid only condition. So this study is a very important study when we are talking to the potential patients, and they say that yes, we can hear and also we can see this in our clinical tests that they can hear, of course, but their scores are like 13%, 7%, 38%, 28%, 21%. This is not enough when they have to be in their social environments, when they are listening, when they're challenging listening environments, and that is why the EAS procedure could benefit them a lot when we can really say that yes, an average of 50% of improvement could also be achieved, and that's achievable. Very interesting. I would also like to show you the US FDA study, which was done in comparison to another implant type, which was the hybrid L. So what you see in the first graph here is the low frequency hearing loss pre-operative versus 12 months post-op in dBHL. So with the straight lateral wall electrode, which is on the left, depicted in color red, so what we see is this was 24.1 dBHL 1 year post-op, and on the right, the yellow graph, you see this is from the hybrid L data, and here you see that the low frequency mean hearing loss was 33.8 dBHL. Also, we see that the sample size was very nice. So here it was 73 patients, and on the right you see the subject size was 50. So this is a very strong evidence which suggests that the Medel's straight electrodes are able to give nice hearing preservation in the long run as compared to the other electrode type. Let's look at the second outcome from the same study. So the mean change in the low frequency pure tone average by more than 30 dB. So with the Medel's electrodes, It was only 21% of the patients where the mean change in the low frequency pure tone average was more than 30 dB, as compared to the other electrode where it was very high and it was 41%. Another interpretation from the same study, so the profound hearing loss in the patients at the time of FDA submission. So with the medal it was only 12% and with the other device it was 44%. So we see that quite a small number of patients had profound hearing loss after 1 year of this procedure. And the most important outcome from this study was this, that the subjects with functional hearing for use of acoustic stimulation, because we want these users to be using their acoustic hearing post-operative, we want to use them, we want them to fit with the hearing aid so that they can use their residual hearing. And with the medal systems, 97% of the patients could still use their acoustic unit, as compared to the other system where there were only 66% of the patients who could use their acoustic stimulation. So what this means is that with the medal device, the users who were chosen for the EAS procedure, they were still able to use the EAS device after the surgery. And also there are a lot of evidences, there are a lot of literature, a lot of studies which also talk about the EAS users who perform very well in quiet surroundings, in background noise, in music, in various difficult listening environments. So we talk about the EAS devices. I would just like to give you a small idea that this remains constant as we can do with the cochlear implant processors, that we can use the same wireless connectivity for our EAS systems as well. So as you see that in the Sonnet, they can use the telecoil, they can use direct audio input, and the Sonnet processor is also 2.4 gigahertz ready, so it is ready for future wireless communication technologies. It is also very nice that the patients can use the Bluetooth neck loops. What you see in this example is the R-Tone 3 Max. And this is also very interesting and nice to know that this device could be very beneficial if the patient is also using a hearing aid on the other side. And so with the help of the telecoil, with the help of the induction loop, both the devices could be both the devices can receive the signal at the same time, and it is very nice for bimodal use. Also, we have the Roger 21 system, which is also now a design integrated system. What you see here, the Roger 21 is now integrated in the Sonnet processor, so there is no need of any external 3-pin DAI receiver to be attached to the Sonnet. So the user can just put the battery pack cover, which already has the Roger 21 system integrated in it. And all the other Roger line of transmitters are all compatible with these devices. So, as a summary, I would like to emphasize again that we have a long history of continuous development of the EAS systems. It is implanted worldwide. There are a lot of centers which are doing this procedure, and they are successfully able to achieve hearing preservation, and the patients are able to use their EAS devices. It is very important that for the group of patients who fulfill the current EAS indication, EAS treatment yields better outcomes than either hearing aid treatment or traditional CI treatment without the hearing preservation surgery. So these patients, if we can identify them well, they can do way better with their hearing aid alone outcome or CI alone outcome. So when the hearing aid and CI, so when it is EAS, the combined mode, their performance is way better than both the devices alone. We can achieve excellent hearing preservation rate, we can have excellent clinical benefits, and there are over 200 publications which support various aspects of the EAS procedure. So these are some of the resources which, if you're interested, you can go through. And I would like to thank you very much to attend this course.